preventive treatment is another treatment which you have to consider in patients with chronic migraine. In 2001, the family care physicians, neurologists, and pain specialists, they came to consensus in the U.S. Headache Consortium of American Headache Society that this could be criteria for make a choice for preventive treatment. So if you have a patient coming with a lot of headaches and they're frequent, then they already qualify for preventive treatment. So our chronic migraine patients. Now the other things to consider if the patient has contraindication to acute therapies. There are some adverse events with acute therapies. Cost of therapies. Some patients will ask you for preventive treatment, and also uncommon conditions are also indicators to the use of preventive treatment. Now, this is a busy slide, and you have some other slide in your handouts. Is that I'll just quickly go over that. Is that in the preventive treatment, we don't have any migraine-specific medications. We use either beta blockers, antidepressants, anticonvulsants, calcium channel blockers, or various other medications. Now, this slide was actually done by Goldsby and his colleagues and published in Lancet. Illustrates the drugs with the most evidence in use in migraine. Propranolol has been used extensively, and it's actually a good medication, and the problem with it can be contraindicated in asthma, and we know that asthma is highly prevalent in migraine population, so you need to be aware of this, and sometimes metoprolol, nadolol, and other medication has been used, but the one which has the best evidence is propranolol. Among the anticonvulsants, valproic acid and topiramate has the highest evidence, and unfortunately there are some side effects associated with valproic acid, such as weight gain, hair loss, and it's contraindicated in pregnant women. It has enormous potential for fetal abnormalities and causing fetal abnormalities, and also it can cause drowsiness, tremors. Topiramate has been very actually, if you look at the data, you see that topiramate has been the highest prescribed medication for migraine prevention in U.S. But unfortunately, it causes paresthesias, it causes cognitive dysfunction. It's very difficult to use in patients who are in school or teachers, doctors, and also there is 30% will actually have weight loss, and it can be significant for some people. So you have to stop the medication. Flunarizine is not available commercially in the United States, and it's used in Canada and European countries. And you can see here, verapamil is not on the list. And I don't know if you guys use a lot of verapamil, but verapamil has less evidence of all of its drugs. Amitriptyline or triptyline has been used extensively in U.S. And unfortunately has side effects, drowsiness, urinary retention, constipation, but good for those who have sleep problems. Effexor or venlafaxine being used also, and as another option. And here there are some medications which are serotonin agonists. They're still being used in Europe. I'm not sure if methotrexate is still available in U.S. It's not, right? Yeah. So actually, it has a good evidence and it has been effective. But unfortunately, because of the side effects such as retroperitoneal fibrosis, it has been discontinued in U.S. The production has been discontinued in U.S. The other compounds which are can be considered and has some evidence is lisinopril and katensartan. Lisinopril is ACE inhibitor, and katensartan is the angiotensin receptor blocker, and both have been shown in placebo-controlled studies to be effective. And of course, the medications patients love because they have less side effects are riboflavin, coenzyme Q10, Petadolix or Butterbur, and feverfew. The data shows that they're effective, but not as potent as the other medications I mentioned. And other treatments we can consider are recently shown that Botox or onabotulinum toxin A has been effective in migraines, in the reduction of migraine attacks by 9 days. Now, there was a huge placebo response in that study, but they also looked at some secondary endpoints where they found that the cumulative number or cumulative hours of the headache, which was actually decreased from 100 to 70. So that was significant. And also there are some endpoints on disability were also improved in that group. Now, neuroblocks has also been used in chronic migraine. Unfortunately, there are no really good placebo-controlled randomized studies, but most of our evidence is from observational studies and small comparative trials. Physical therapy has been effective. There is some evidence for that. And of course, biofeedback relaxation therapy. There is a study where actually they, by Kenneth Holroyd from Iowa, who showed that using the behavioral approaches in the treatment together with amitriptyline was more superior than amitriptyline alone. So that indicates the significance. And then we have the intravenous infusion, which can be given in the hospital or in the outpatient centers. And the reason we use them is that if you have a patient with medication overuse or intractable headache, which has been just increasing in severity, in order to get them to relieve from that and help the detoxification, then you can use these medications. They're usually given over several consecutive days and has been shown to be effective, especially dihydroergotamine and neuroleptics. Now, and valproic acid as well. For steroids and for magnesium and Benadryl, there is little evidence. And for non-steroidals, is intravenous Toradol has been shown to be effective and superior to placebo. So this is my last slide, and I'd like to hear any questions.
Sure. I'm just wondering, you commented on using Protobar and magnesium. Do you guys ever recommend, or can you talk a little bit about the evidence for homeopathy or acupuncture?
So the acupuncture, there are some studies. So there are some studies which have been positive and some negative. So that's why it's been problematic to make any suggestions about use of acupuncture. But for some individuals, it helps, and I would not advise not to use it. So, and we have some patients who get craniosacral or homeopathic therapy, and it's effective. So what I say to my patients usually is that I'm not against the use, and if it helps, it's really great, and it will help my